Okay, we're going to bring up our women's health experts, and Dr. Diana Ramos, our board member and public health official from California, is coming up to introduce them. And if you can all come up and have a seat up here.
I think actually we're going to call you up at the end for questions. So good morning, buenos dias. Please stand up, get some oxygen flowing. I know the coffee may not be kicking in now, it's wearing out. Okay, big stretch. So now that you're energized, I think, for one of the most important sessions, which is women's health, I hope that you're going to be as excited to learn about the fantastic information that we have to share. The one thing I want to do is I want to start out by bringing attention to the Women's Preventive Service Initiative. This handout was in your bags that you all received, and this is a gold mine. And so why do I say that? If you open it up, if you have a woman in your life, if she's an adolescent, a reproductive age woman, perimenopausal, postmenopausal woman, a woman in your life, this is your handbook. Why? Because this is a compilation, it's a well-woman chart of what physical exams, what component of a physical exam should be done depending upon, or what is recommended to be done depending upon the age of a woman. It also includes prenatal as well as postpartum recommendations. The most important, and I think the best part of this, is that this was done as a collaborative initiative led through ACOG, the American College of OBGYNs, and it is really a compilation and a multi-practice effort from the American Family Association, the American College of Physicians, the the Nursing Association. So it really is not just the American College of OBGYN, but it is a cross-collaborative effort. So please look at this. Anything that is covered by the Women's Preventive Service Initiative is covered as an essential health benefit. That means that it is available without a copay to your patients. So the Women's Preventive Service Initiative right now is actually working on billing codes so that you can bill for these. It's wonderful to do the right thing. It's even better when you do the right thing and you get paid for it. So I bring the attention to this. So let me get started, and I want to start out by thanking Dr. Nelly Correa for being a visionary on this panel. She was the one that said we really need to focus on women's health because women are the core of our Latino population, our families, right? We drive the healthcare, not only in the Latino population, but in healthcare decisions as well. So it gives me great honor to bring up and introduce our panelists. The first panelist is Dr. Tiffany McNair, MD, MPH, and she is going to be speaking to us on improving maternal health in the U.S. Dr. McNair is the Director, Division of Healthy Start and Perinatal Services, Bureau of Maternal and Child Health, Resources and Services Administration for the U.S. Department of Health and Human Services. She is at HRSA. Some of her key programs include not only the Healthy Start Initiative, which is a grant providing over $100 million in funding to improve perinatal outcomes and reduce racial and ethnic disparities in infant mortality, as well as the Alliance for Innovation on Maternal Health, a partnership to combat maternal mortality and severe morbidity, and through the design and implementation of evidence-based maternal safety bundles. And she also is the lead for the Women's Preventive Service Initiative. So the handout that you are in your bags that I spoke about, that is sponsored by HRSA, she oversees this. Prior to her tenure at HRSA, Dr. McNair was a division director and medical officer within the Prevention and Population Health Group at the Center for Medicare and Medicaid Innovation, also known as CMS. And before joining CMS, she was a White House fellow. And in that capacity, she served as a policy advisor and public health consultant to the Vice President of the United States, providing guidance and technical assistance to the White House advisor against violence against women. Dr. McNair graduated from Harvard College and received her MD from Harvard Medical School and MPH from Johns Hopkins Bloomberg School of Public Health. Please help me welcome her.
Thank you, Dr. Ramos, for that very warm introduction. And good morning, everyone. It's great to be here. I really appreciate this opportunity to be a part of this panel on women's health. And I hope that I'm able to do everything. I'm not as tech savvy as I'd like to be. So as an OBGYN and a preventive medicine physician, as well as a public health practitioner, I really am grateful to serve in support of what I'm sure is a shared pursuit in this room, and that's to achieve healthy and thriving communities, particularly among the most vulnerable under our care. And now I really do want to kind of take the conversation a little bit further by specifically focusing on the advancement of health and well-being among women, children, and families through the work that we're doing in the Maternal and Child Health Bureau at the Health Resources and Services Administration, which we also call HRSA. So our main objectives in the short time that I have with you today are first to provide an overview of the Bureau for those of you who may not be as familiar. Then I'd like to briefly discuss some of our key investments to improve maternal health, including our burgeoning portfolio on reducing maternal mortality and severe maternal morbidity. And then perhaps most importantly, I'd like to hopefully inspire your future engagement in these efforts to improve the health of women. And by extension, we know that if we're doing that for women, then we're doing that for children, for families, and for our communities. And then I look forward to the dialogue that we'll have following the panel. So the Bureau is housed within HRSA, as I described, and is one of the operating divisions in the Department of Health and Human Services. You heard from Dr. James, from CMS, also FDA, CDC, et cetera. And the Bureau is really one place within the government that is responsible for improving the health of all of America's mothers, children, and families, as you can see, for our mission. And it's through this mission that we envision America where all women, all children, and all families are healthy and thriving and have the opportunity to reach their full potential. So the Maternal Child Health Bureau represents approximately 11% of HRSA's budget and also has 11 different legislative authorities. Today, what I'm going to do is focus on our three largest investments, which are at the top. The first one is the Maternal and Child Health Block Grant, which represents approximately half of our budget and includes an allocation to states as well as discretionary set-asides for special projects of regional significance, and I will talk a little bit about that later on. And then about 30% of our budget is for the Maternal, Infant, and Early Childhood Home Visiting Program. Some of you may have heard of that, also called MIECHV. And then lastly, about 10% of our budget goes to the Healthy Start Initiative. The remainder of our investments are in 8 categorical program areas, which cover a wide range of topics that seek to tackle crucial issues surrounding maternal and child health, but they do have a slightly more limited budget. So I'll start with the Title V Maternal and Child Health Services Block Grant. With the passing of the Social Security Act in 1935, the federal government through Title V pledged its support to state efforts to extend the health and welfare services for mothers and children across the country. Currently, the Title V Maternal and Child Health Services Block Grant, which we affectionately refer to as Title V, is the public health system for women and children in the country, and it is actually the oldest federal-state partnership. As the Bureau's largest investment, Title V funds 59 states and jurisdictions to provide health care and public health services to reach an estimated 56 million people. This includes 86% of all pregnant women, 99% of all children, of all infants, and 55% of all children, and this includes children with special health care needs. So 2 hallmarks of the block grant to states include its flexibility and the accountability associated with it. The block grant format gives states flexibility in the use of their Title V funds that they receive to address the unique needs of populations served. But there are a few key requirements. First, states must spend at least 30% of their federal funds on children and youth, and this includes youth and children with special health care needs, and then at least 30% on preventive and primary care services for children. Every 5 years, states are also required by law to do a comprehensive needs assessment, including to identify the needs of mothers, children, and families. And then based on this needs assessment, they identify 7 to 10 priority needs, which will inform the development of a 5-year action plan. The Bureau ensures state accountability through our technical assistance and our performance measurement. Specifically, states are required to report a variety of measures across 5 population domains, and one of those domains is for women's health and maternal health. And that helps to assure continued progress through key national and state goals. So it's in that vein, as you can see here, there are 15 national performance measures across these 5 population domains. And of the 15, 4 relate to women's and maternal health explicitly. That includes the well-woman visit, low-risk cesarean deliveries, preventive dental visits during pregnancy, and smoking during pregnancy. What we're going to do is talk a little bit more on the next slide about the relationship between these measures and the action plans that states develop and implement to address the unique needs and priorities. So the program uses a 3-tiered performance framework. The national outcome measures are really sentinel indicators of maternal and child health, and then the national performance measures are more intermediate measures that influence those outcome measures. States also develop evidence-based and informed strategy measures for each performance measure. So let's just break this down and take an example of maternal mortality or severe maternal morbidity as a national outcome measure. Clearly, we know this is an important indicator of maternal and child health in our population. But what we don't want to do is wait until we tragically experience a maternal death to find out whether we're actually on the right track to making progress on this indicator. So what happens is states will look at measures that are related to maternal mortality and that are predictive of the outcome. For example, access to well-woman visits, rates of smoking in pregnancy, and frequency of low-risk cesarean deliveries. And then what they do is we take it one step further. As part of their accountability, states then submit an annual action plan and describe what steps they will take to address key priorities that are tied back to the performance measures and to the national outcome measure. I've listed here a few examples of evidence-based strategies that are being implemented in states across the country, including increasing referrals to quit lines for mothers that are smoking during pregnancy, and also promoting quality improvement initiatives, like the implementation of maternal safety bundles in response to obstetric emergencies. So there's much more to tell and to learn about Title V that I actually do have time to share today, but if you're interested, you can visit the Title V information system, and I've included the website here for you, which is available to you online, and allows you to get both a national level overview as well as state-specific snapshots on their maternal and child health activities. Before I move on to the MIECHV program, I do want to highlight just one other project under Title V's Special Projects of Regional and National Significance, also known as SPRANS. Funding under SPRANS aims to address critical and emerging issues facing the maternal and child health population, as well as promote collaborative learning to spread best practices. And one key example of a SPRANS activity that's related to maternal and child oral health is the Center for Oral Health Systems Integration and Improvement, also known as COSI. In 2017, the Bureau funded the National Maternal and Child Oral Health Resource Center at Georgetown University to administer the COSI project. COSI works with key stakeholders to improve systems and care in support of a quality improvement, patient-centered framework to address the oral health needs of the maternal and child health population. And as you can see on the slide, the consortium does have multiple partners of which you may be familiar, and they have 3 main goals. The first is to provide Title V recipients with technical assistance and training. The second is to identify maternal and child health, oral health quality indicators to monitor specific systems of care. And then the third is to develop and disseminate resources to professionals that are working in or with Title V agencies. So now I want to turn to the Maternal, Infant, and Early Childhood Home Visiting Program, again also known as MIECHV. The MIECHV program was established under the Affordable Care Act and is administered in conjunction with the Administration for Children and Families. As the second largest investment in the Bureau, it was created to support voluntary, evidence-based home visiting services for at-risk pregnant and parenting women and for young children through kindergarten entry. MIECHV builds upon decades of evidence surrounding home visiting, which I hope many of you are familiar with, and this involves trained professionals like nurses, social workers, who meet with families in their home to identify and address critical needs to advance the health and wellness, particularly to improve maternal and child health outcomes, including positive parenting, school readiness, and building economic self-sufficiency. States, territories, and tribal entities receive funding through the MIECHV program and are the driving force behind it. And here I'm just showing you the geographic reach and scope. There are grantees in every state across the nation in which more than 150,000 parents and children have been served, and over 930,000 home visits are conducted, and this was in the last fiscal year alone. As with Title V, states design their program based on a needs assessment, and they do have flexibility to tailor their programs, again, to the unique needs of their communities. They're also able to choose from 18 evidence-based home visiting models. Some of you may have heard of Nurse-Family Partnership, for instance, which is geared towards first-time moms. And this, again, is to best fit the community's needs, the capacity, and the resources. Now, MIECHV does outline populations that are prioritized as being the most vulnerable. This includes low-income communities, adolescent, pregnant, and parenting girls, families with a history of substance use, of violence, and other adverse experiences. And in 2018 alone, over 70% of families served within the MIECHV program were less than 100% below the federal poverty level. Over 75% relied on Medicaid or CHIP, and over 13%, or excuse me, approximately 13% of newly enrolled participants were pregnant teens. And then finally, over 2/3 of the participants belonged to racial and ethnic minority groups. This included those from Black, Hispanic, Latino, and American Indian and Alaska Native communities. As you can see, the grantees have provided 5.2 million home visits over the last 7 years. So I'm sure you're all asking yourselves, but really, how is the program doing? So from its inception, MIECHV has adapted a learning approach that focuses research and evaluation efforts on improving program effectiveness and building on the existing knowledge base that I described earlier. As you can see here, there are 6 benchmark areas with corresponding measures. And while at the top you'll see maternal and newborn health is a specific benchmark category, I think we all know that all of these areas ultimately impact the health of women and children. In 2018, all states and all but 1 territory showed improvements in 4 out of 6 of these benchmark measures. And just to give you a few examples of ways that MIECHV is serving families, 78% of caregivers were screened for depression, and 82% were screened for intimate partner violence soon after their enrollment, while 70% of children had family members that read to them daily. And all of these are really key indicators as we think about improving and sustaining improvement in the health of women and children. So next, I want to move to the Healthy Start Initiative, Eliminating Disparities in Perinatal Health, also known as Healthy Start, and which happens to be a program within my division. Really proud of this program. And it is the 3rd largest investment in the Bureau. The purpose of the Healthy Start program is to improve health outcomes before, during, and after pregnancy. And you heard Dr. Ramos share this, to reduce racial and ethnic disparities in rates of adverse perinatal outcomes, particularly infant mortality. And to do this, the program provides grants totaling over $100 million to high-risk communities with infant mortality rates at least 1.5 times the US national average, as well as high rates of other poor perinatal outcomes, low birth weight, preterm birth, maternal mortality, and severe maternal morbidity. Grantees do include public and private entities, as well as faith-based, community-based, and tribal organizations. Now, Healthy Start funding supports implementation of community-based interventions to support some of the most vulnerable women, children, and families in our nation. And there's a number of goals that are intertwined with this. It's to strengthen the health workforce in caring for such populations. It's to build more effective and efficient service delivery systems. And perhaps most importantly, it's to promote and improve health equity across the participating organizations. I note here on this slide the program's scope in 2017. However, we are really excited that we just announced a new cohort of Healthy Start grantees for the next 5-year cycle, and this was just announced at the end of last month. I've shown you a map of that new group of grantees. And as you can see, the geographic diversity is vast. And we're excited to share that among the 100 healthy sites in this round, that the reach extends to Puerto Rico for the first time. On that note, I will mention that HRSA, some of you may know this, HRSA previously did set aside funding for border Alaska and Hawaii projects in our past funding cycles. This was also known as the Border Initiative. This was set aside from general population grants in recognition of the disparities that do exist along the US-Mexico border. And while that is no longer a specific initiative that we have in this current cycle of grantees, our commitment remains strong to advancing the efforts of Healthy Start programs that serve Hispanic, Latino women, children, and families without limitations in terms of geographic location. Particularly given that we know that in many cases, Healthy Start programs represent the only available and trusted source of care to reach some of these families. So Healthy Start's presence in highly vulnerable communities, such as among racial and ethnic minorities, not only serves to improve maternal and child health, but I would argue also strengthens family resilience and helps us to move the needle on overall collective impact. So let me briefly share some of our work surrounding the reduction and ultimately the prevention of maternal mortality. As many of us know, the rate of maternal mortality and severe maternal morbidity is rising, with approximately 700 women dying in the US annually from pregnancy or delivery complications. Moreover, the US now has a higher maternal death rate than many other high-resource countries. The most common conditions include those that are listed, but I do want to emphasize, especially given what we've heard earlier today, it's important to note that mental and behavioral health conditions, including opioid use disorder, are now leading causes of maternal mortality in many states. In addition, disparities do exist along racial and ethnic as well as geographic lines. So Black women being 3 to 4 times higher than white women to die compared to white women of maternal mortality and severe maternal morbidity. And also, medically underserved areas such as rural communities have higher rates of maternal mortality. We also know that 60% of pregnancy-related deaths are preventable. So improving maternal health outcomes and access to quality maternity care services is central to our mission, and reducing the US maternal mortality rate is a top priority in support of this mission. I'll just highlight a few key endeavors that are underway in the Bureau to combat maternal mortality. First, we are catalyzing quality improvement in maternal safety, and I mentioned some of this a little bit earlier. This is through the Alliance for Innovation on Maternal Health, or AIM. This is funded through the Title V SPRANS funds, again, special projects for regional and national significance. And it's a national data-driven quality improvement initiative that's based on proven implementation approaches to improving maternal safety in hospital settings. AIM works through state teams and health systems to align national, state, and local quality improvement efforts to improve overall maternal health outcomes, and often are working in conjunction with some of the regional perinatal quality collaboratives. AIM is now working in 23 states, and there's some others that are in the pipeline, and has implemented maternal safety bundles in more than 1,000 birthing facilities across the country, reaching nearly 2 million annual births, or around half of all annual births in the US. Our maternity bundles, which you can find on the website, range from a focus on obstetric hemorrhage to hypertensive disorders in pregnancy, and also to reducing peripartum racial disparities. Another lever for combating maternal mortality has been the convening of global experts to share best practices, to problem solve, and to plan strategic solutions to addressing maternal mortality and severe maternal morbidity. So in June of last year, we held a maternal mortality summit at HRSA that convened experts worldwide to share these innovative strategies. Leading subject matter experts hailed from the US, from Brazil, from Canada, from Finland, India, Rwanda, and the United Kingdom, as well as representatives from the World Health Organization. And in the course of this convening, experts developed recommendations on a wide range of issues that impacted maternal mortality, everything from access to care, quality improvement, workforce development, data needs, the utilization of a life course approach, which we know is really important. We can't divorce maternal health from child health and all the way through a woman's entire life. And then improving the quality and consistency of maternal mortality review committees in states across the country. So finally, as we look ahead to expanding our reach related to maternal mortality reduction, we're excited about a new appropriation for this fiscal year, 2019, which has included additional funding provided to expand the Alliance for Innovation on Maternal Health that I described to all US states, the District of Columbia, and US territories, as well as tribal entities. We also have a new state maternal health innovation grants that will support state-led demonstrations to implement evidence-based interventions that will address critical gaps in maternal care service delivery. And then finally, within the Healthy Start program that I described, we have a funding increase of $12 million that will support the hiring of clinical service providers who will provide direct well-woman care and access to maternity care services in Healthy Start sites across the US. So as I close, I'd like to just briefly highlight how we are advancing maternal and child health as a bureau through our promotion of diversity among those on the front lines, like all of you. As I mentioned, improving workforce development was a critical finding in the maternal mortality summit that we had last summer. And the Bureau is focused on creating and nurturing a pipeline of talented professionals that tackle all of these issues that I've described today. HRSA's maternal and child health training programs have a particular focus on recruiting trainees from diverse populations and disadvantaged backgrounds, including Hispanic, Latino healthcare and public health professionals. In fiscal year 16, these data come from that, approximately 10% of medium and long-term trainees were identified as Hispanic or Latino. And just to give you a sense for what that means, medium or long-term, the term refers to the number of contact hours or the intensity of exposure to the training. So the medium is 40 to 299 hours, whereas the long-term is 300 plus hours. So you can think of the long-term as equating essentially to a full-time fellowship for those who participated. I should also note that participating clinicians were able to receive continuing education credits through this. The Bureau also supports 2 training programs, the MCH Pipeline Program and the MCH Catalyst Program, which report even higher percentages of Hispanic and Latino trainees. The Pipeline Program recruits undergraduate students from economically and educationally disadvantaged backgrounds to promote their inclusion in maternal and child health professions. And the Catalyst program provides exposure to maternal and child health arena to graduate students. And this includes individuals from backgrounds who are underrepresented in the maternal and child health field. So with that, I'll stop there and end where I began. As I hope that you've learned today, the Bureau really is committed in its wide-ranging portfolio of programs, as well as our workforce development initiatives, to improve maternal health. And this is not simply, as I said earlier, to advance the health and well-being of women, children, and families, but as you can see here, to ensure a healthy future for us all. So thank you so much for this time. I look forward to our dialogue.
Thank you, Dr. McNair. And now it's my pleasure to bring up Dr. Carol Brown. Dr. Brown is a board-certified gynecologic oncologist who is the Associate Cancer Center Director for Diversity and Health Equity at Memorial Sloan Kettering Cancer Center. She holds academic appointments as attending surgeon and member of the Memorial Sloan Kettering Cancer Center and professor of obstetrics and gynecology at Cornell University, Weill Medical College in New York. Dr. Brown's career is focused in 3 areas: providing high quality and compassionate surgical care to women with gynecologic cancer, the reduction and elimination of cancer health disparities experienced by medically underserved populations, and promoting public policy to increase awareness, improve care, and increase research funding for gynecologic and other cancers, both locally and nationally. Dr. Brown is the immediate past president of the Society of Gynecologic Oncology, the first Black female leader in the 50-year history of the group. And she has, yes, well deserved. She is also an alumni of Harvard Medical School at Columbia and has received numerous teaching awards as well as patient recognition award, outstanding physician. Dr. Brown. Thank you.
Good morning. I am so honored to be here and to have been invited by my esteemed colleague, Dr. Ramos, who, as you know, is a force of nature in terms of her activities and leadership in OBGYN and preventive medicine. And also, I am very honored to be here speaking. Dr. Rios is an amazing legend that we all look up to. So thank you very much for inviting me. So I'm going to take this opportunity to do a couple of things. I want to, knowing who the audience is, I want to bring home to you a couple of messages about GYN cancer. And when we talk about GYN cancer, I'm talking about cancers below the belt. So all the cancers that affect women's reproductive organs. We're not going to talk about breast cancer today. And I want to give you a little bit of an update on some key messages for you as healthcare providers who interface with women, because as was mentioned earlier, that how our dental professionals and providers are often the first ones to pick up on head and neck and oral cancers. You all, as primary care providers and OBGYNs who are seeing women, have the opportunity to be the ones who can diagnose and make referrals for cancers below the belt. And then I also want to focus a little bit about some of the disparities in GYN cancers and how you and we at SGO can work together to get rid of them. So I don't have any financial disclosures. So a brief slide about GYN cancer in Hispanic women. So the first thing I will say is that I'm glad that we now have this slide. I've been in the sort of diversity, disparities, cancer business since 2005, and they didn't used to even have statistics. Statistics were only black and white. So we now have statistics for Hispanic ethnicities, but as all of you know, I don't have to tell you that when the term Hispanic brings together many, many different diverse populations that have very different risks for different types of cancer. But this is the best we have right now. And in terms of the GYN cancers, or cancers below the belt, in 2018 there are almost 12,000 new cases and 2,700 deaths from GYN cancers. So that's ovarian, uterine, cervical, vulvar, and vaginal cancers. So some other key take-home points about GYN cancers in Hispanic Latino women. Cervical cancer, the most important one really, because cervical cancer has a 40% higher incidence and a 25% higher mortality in Hispanic women than in non-Hispanic white women. So, and there are a variety of reasons for this. Some of it, in some groups, it relates to access to prevention and screening and treatment. But in other groups, there may be some biologic or molecular genetic reason for this in terms of the types of cervical cancer that people get. And again, because research into other than black populations in terms of minority groups, and I say minority because you heard earlier today that very soon you are no longer going to be a minority, so I try not to even use that term anymore. But minority groups, really have higher risks of cancer and worse disparities. And for Hispanics, cervical cancer is really the one. Uterine cancer is diagnosed at a later stage, and in general population in the United States, Hispanic women have a lower survival with uterine cancer. However, for black women with uterine cancer, there is almost a 20% lower 5-year survival that has persisted compared to non-Hispanic white women. And this definitely has something to do with access to care, but also molecular biology, and I'll get into that in a minute. And then ovarian cancer. So there's very little research, just beginning to be research about Hispanic women in ovarian cancer, but a few different studies have shown that women from Puerto Rico have the lowest cancer-specific survival of any racial or ethnic group that has ever been studied with ovarian cancer. And it is starkly, it's just like unbelievable. And actually, I should mention that the incidence of cervical cancer in women from Puerto Rico is about twice as high of Hispanic women in general and 3 times as high as non-Hispanic white women. So again, this is something that we really have to focus on. So now I want to switch for a minute and just give you some clinical pearls to update you on what are some really important take-home messages for GYN cancer. So all of you know that this is the HPV virus, right? The double-stranded DNA virus, the most common sexually transmitted, not disease, sexually transmitted infection in the world. It's not a disease, it's an infection. Please remember that when you're talking to your patients. But also HPV, I think it's a magic virus. Why? Because it's the first virus since hepatitis C since hepatitis B that is a cancer-causing virus. And the take-home message for all of you is that it's not just cervical cancer. True, HPV is responsible for over 90% of cervical cancers, but look at all the other cancers that are caused and related to HPV. Oropharyngeal cancers, anal cancer, vaginal and vulvar cancer, penile cancer, and non-melanoma skin cancer. The reason this is such exciting news and so important for you to remember is because you are taking care of men and women. You have patients who have in their power the ability to prevent, primary prevention of all of these cancers very simply with something we're all used to doing. And what is that something? The HPV vaccine. And specifically, there is now a non-covalent vaccine that protects against 9 high-risk types of cancer-causing HPV, and I've highlighted here that just recently, this vaccine is now approved in boys and girls, men and women aged 9 to 45. That is a big change. Until a few months ago, it was only up to age 26. It's now 9 to 45. Everyone in here can tomorrow or next week when you're seeing patients, you can remind every patient you see, if they have children, get them vaccinated for HPV. And now you can remind all of your patients, male and female, who are younger than 45, that they can get vaccinated and help prevent all of those cancers that we talked about. This is huge. Biggest cancer prevention thing ever. Okay, now I want to talk about endometrial or uterine cancer. And the reason I'm focusing on endometrial cancer today is the same thing. You all are at the forefront of diagnosing this disease. So I want to give you a little bit of a lesson. Key points. It's the #1 GYN cancer in the United States. It's the most common cancer that women get after breast cancer. Its #1 symptom is abnormal bleeding. If any of you have female patients, you are going to hear them talk about abnormal bleeding, and I'm going to ask you to listen carefully when they talk. Don't dismiss it, and think about what I said to you today the next time you have a woman patient that says she had abnormal bleeding. And it is also the #1 reason that women over 40 get something called an endometrial biopsy, which is a procedure that's done in the office by primary care providers, by OBGYNs. So who needs to get an endometrial biopsy? My little graph here basically is saying all the different types of what's abnormal bleeding. Well, abnormal bleeding is postmenopausal bleeding. Abnormal bleeding is perimenopausal bleeding, when that woman is transitioning between her periods completely stopping and still getting them. Abnormal bleeding is a woman who is not ovulating regularly, so she may only get 2 or 3 periods every 9 months or so. Abnormal bleeding, a woman who should get biopsied, if you do a pap smear on a postmenopausal woman and you see endometrial cells, that woman needs a biopsy. Women who have a thickened endometrial stripe on ultrasound that are postmenopausal. And women who are still getting their periods if they're over 55, because the median age of menopause in the United States is 52. So if you're seeing a woman that is still getting regular periods and she's 55 or 56, she really should have this painless, low-tech, easy to do, well, it's not painless, particularly if you take an Advil first, sorry, I should have said that. But it is a very simple procedure that any primary care provider can do in the office. So I would encourage you, if a woman complains of abnormal bleeding, get an ultrasound and do a biopsy. If she's postmenopausal, she needs a biopsy, no matter what. And the reason is endometrial cancer. Now, another very important take-home message is Lynch syndrome and endometrial cancer. Lynch syndrome is a hereditary cancer syndrome associated with early age in the family, early age of onset of colon cancer and endometrial cancer. Take a family history. I know you all already do this, but this is another way that you can really impact cancer and prevent cancer, is by listening carefully to the family history. When you hear colon cancer in 2 or 3 more people, you need to think about Lynch syndrome. And for women, Lynch syndrome can mean endometrial cancer at very young age. The average age of onset for Lynch syndrome-associated endometrial cancer is age 48. Now, the reason I'm bringing this up, this is not a rare syndrome. We are finding out that now we screen all women who have endometrial cancer, get screened with immunohistochemistry on their cancer for Lynch syndrome, and we're finding that it is actually very, very common. So be aware of it and be aware of family history. Other cancers that are associated with it are ovary cancer, small bowel cancer, kidney cancer, ureter cancer. So ask your patients about it. So this is the main thing I want to tell you about, is that it looks like there's an epidemic of endometrial cancer. So it used to be a disease of old women in their 70s, 80s with very obese women. That has completely changed. The dynamic in the picture has completely changed. Our average patient that we're seeing is in their mid to late 40s, early 50s. Many of them are still getting their periods. And the number of cases, as you can see here, has increased 57% in just 10 years. The number of deaths has also skyrocketed to the point that endometrial cancer just 4 years ago was the number 8 cause of cancer death in women. Now it's number 6. And next year, there are probably going to be more deaths from endometrial cancer than ovary cancer, which is really bad because ovary cancer is not very curable. Endometrial cancer is highly curable. So this is alarming. It's alarming to people in the GYN oncology community. It's probably alarming to those of you who are in public health and epidemiology. And why is this happening? We really don't know, but it does correspond with the obesity epidemic. It does correspond with the fact that hormone replacement therapy really went out of fashion completely when the Women's Health Initiative results were released about 10, 15 years ago. And the fact of the matter is that hormone replacement therapy, particularly combination hormone replacement therapy, protects against endometrial cancer. And one theory is that so many women across the United States stopped using hormone replacement therapy postmenopausally, stopped taking progesterone, that allowed this disease to increase. But it definitely is a very significant public health problem. So I want you all to be aware with it. Bottom line is, you can prevent cervical cancer, head and neck cancer, anal cancer, non-melanoma skin cancer by making everybody you know get vaccinated and their kids. And you should think about endometrial cancer when your female patients say they had a weird period, they had a heavy period if they're in their 40s. If you're not their OBGYN and you don't do GYN, send them to see their gynecologist, and doing a biopsy is an easy thing to do. Okay, now I want to talk a little bit about the disparities and equity. So this is, again, we don't have good data yet to make these kinds of charts for Hispanics and other minority groups, but for African American women, for ovary, uterine, and cervical cancer, the main GYN cancers, there are significant disparities, as you can see here, in terms of 5-year survival. This slide is very important because we need to remember that disparities in many health conditions often are related significantly to poverty and access. And I love this study because it showed that patients who had Medicaid had worse cancer outcomes than patients who had no insurance. And Medicaid is supposed to provide access to care for everyone, but one thing that we have found, particularly in the New York and tri-state area, is that particularly with Medicaid managed care, a lot of these plans are not giving patients access to high quality cancer care because that may not be available in the community hospital system that they're in. So how can we achieve equity in GYN cancer? There are basically 2 ways you can do it. You can bring the women that are at risk, that don't have access, to the access. You can bring them to the resources. And where are the resources for treating GYN cancers? Well, they tend to be concentrated in cities, not in rural areas. They tend to be concentrated in areas that have academic or cancer centers. This study shows a population look at what's going on in the United States with ovarian cancer. And it basically shows that if you're poor, if you have Medicaid, if you are Black, and there's other data that shows if you're Hispanic, you have a worse outcome from ovary cancer, looking at the general population, both based on race, ethnicity, and socioeconomic status. This is data from ovarian cancer outcomes at a high volume cancer center that I happen to work at, and I'm an author on this paper, but you can see that when we looked at our ovarian cancer outcomes by either income or race and ethnicity, there was no difference. And we found actually at Sloan Kettering that Hispanic Latino women have a better survival than any other group, which we're trying to understand why that may be. So bringing the women to the resources for GYN cancer can help. But the fact of the matter is that most patients with cancer in the United States, which is something that working with Vice President Biden taught me, 70% of people with cancer get their cancer care in their community. They don't go to Sloan Kettering. They don't go to MD Anderson. They don't have a way to get there. It's not practical. It's not feasible. So we have to find a way to bring the resources to the women where they live. And we have a program that I do at Sloan Kettering called the Cancer Health Equity Research Program. We believe very strongly that you can achieve cancer health equity through participation in clinical trials. And so we bring Memorial Sloan Kettering clinical trials and National Cooperative Clinical Trial Network trials to women in their community hospitals, working with Sloan Kettering research staff and with the local providers who are providing their cancer care there. So this is one way to do it. The organization that I work with, the Society of Gynecologic Oncology, definitely has a focus on achieving equity. And like your group, we do a lot of advocating with the government and lobbying. We've been very successful with research funding and preserving research funding for clinical trials and research in GYN cancers. But we also are really advocating to make sure their clinical trials and access to clinical trials are available. The other way that SGO is really trying to work towards achieving equity in GYN cancer is through outreach. And we have our foundation. You all have a foundation. We have the Foundation for Women's Cancer, which is our foundation for our group. This is our website, the foundationforwomenscancer.org. We have lots of educational material available. We have courses that we do. We go out into the community and we partner with providers to do education outreach screening. And so you can go to this website and see, and every year on November 3rd in 2019, we have a race to end women's cancer here on the National Mall to raise awareness, and we get great participation from the community. So I'll stop there and look forward to having questions with you later. Thanks.
Thank you, Dr. Brown. Great presentation. And now I want to introduce, it gives me great pleasure to introduce our last speaker, Dr. Ana Munné. Dr. Munné was born in Barcelona, Spain, educated in Europe, and graduated with her MD and DDS from the Universidad Central de Barcelona. Dr. Munné came to the United States, studied and worked at the University of Texas Dental Branch in Houston, Department of Periodontics, and obtained her certificate in periodontics and her Master's of Science degree. She taught and did research as a visiting assistant professor in the Department of Periodontics. She is currently practicing in Houston, Texas, has been practicing there for over 20 years, and her practice focuses on periodontics, bone regeneration, periodontal Botox, cosmetic treatments, laser dentistry, dental implants, and mini dental implants. She is the previous past president of the National Hispanic Dental Association, and she's going to be speaking to us about periodontal changes through women's life stages. Thank you.
Actually, I can use this one. Thank you. Thank you so much for this wonderful introduction, Dr. Ramos, and for this opportunity to be here today under such distinguished audience. I don't have a lot of time to have my topic, but I'm certainly going to do my best. I think that my topic is very interesting. We also have blood, so hopefully that is going to keep you awake. And, you know, I'm going to be talking about periodontal changes through women's life stages. And this is a program that I want to thank Sun Stars Americas for sponsoring and contributing to us learning a little bit about dentistry and periodontics, which I'm so passionate about. And I want to go ahead and start reviewing a little bit like the anatomy, just for those my fellow physicians that haven't seen that since medical school. Let me figure this out for a second. And just a brief description to remind you that the periodontium is actually all the apparatus that surrounds the teeth, and they're responsible for supporting the teeth. And that comprises not only of the bone, but also the soft tissue, which is the attached gingiva, the mucosa, and the periodontal ligament. The periodontal ligament is very important because it's crucial in the regeneration, as well as the cementum, which is the layer that is deposited immediately on top of the dentin. That cementum is as well crucial for regeneration, where you guys hear about patients that have bone regeneration, because without cementum, we are not going to have a true regeneration, because there will not be a development of the periodontal ligament. So we would only be able to have an ankylosis. And just reviewing briefly, what are the etiologic factors of periodontal disease? Well, mainly we talk a lot about bacteria. And we know that the red complex bacteria, especially for Porphyromonas gingivalis, Ternella forsythia, and Treponema denticula, are the very responsible. But you know, all those biofilms are very complex, and we also know that actinomyces, actinomycetin comitans, as well as achinelical rodents, are responsible for the more aggressive forms of periodontitis, like rapidly progressing and prepubertal and juvenile forms. And we're going to pass this slide and talk a little bit about different types of pathology that we're seeing in periodontics. And we're going to talk about gingivitis, necrotizing periodontitis, periodontitis as manifestation of systemic disease, periodontitis as per itself, gingival recession, tooth loss, tooth caries, and xerostomia. And some of the conditions actually that we see signs and symptoms of periodontal disease are redness, edema, gingival bleeding, increased gingival crevicular fluid, clinical attachment loss, periodontal pocketing, gingival recession, radiographic alveolar bone loss, bleeding upon probing, suppuration, increased tooth mobility, tooth drifting, tooth loss, and bad breath. And I want to show you this photo here. This is actually a patient that presents with periodontal disease at different stages. You can see in the top slide that there's very mild signs of disease. There's definitely some recession. Sorry. There's definitely recession, and you can see a very thin periodontium, is very thin gums, but very few and little signs of inflammation, maybe on the posterior area. But actually, years later, in the slide on the bottom, you see that there's tremendous amount of bone loss, destruction, there's shifting of the teeth, there's open spaces, there's migration of teeth. Teeth are mobile, and at this stage, they're about to be lost. This next case actually is a case of gingivitis. And just to show you that gingivitis can be pretty dramatic as well. This is a patient that does not have any bone loss, so this is what we consider a gingivitis. But in this case, there's a tremendous amount of response to plaque. This case was biopsied because it had to be done a differential diagnosis with gingival hyperplasia as well as gingival fibromatosis, which is a genetic disorder. Unfortunately, this case had to be treated with surgery because of the extreme amount of granulomatosis that was in the gum. But the resolution was quite excellent. And I want to show you also different cases of periodontitis, because periodontitis comes with different looks, and it always looks the same. And you can see in here that there's patients that actually present just no recession at all and just a little bit of gingival inflammation, but when the dental professional probes those patients, we see that actually there's signs of bone loss, there's pocketing, and there's radiographic evidence of bone loss as well. Other patients on the other side, you can see in the slide in the middle on the bottom, that there's what we call horizontal bone loss, and this patient actually has severe recession as well as crowding. There's also extrusion of the teeth, so there's a passive eruption of those teeth, and we can see that there not only there's a lot of bone loss, but there's also like the teeth are coming out of the bone. And other cases that, you can see a combination of some of them with very severe amount of gingival inflammation. You can see evidence also of some suppuration and necrosis, like a slide on your right bottom side, that you can see that there's been tissue necrosis there as well. And I want to show that slide with the tartar because I think that tartar is that silent bone killer, right? We don't think that tartar could remove bone, but tartar is responsible also for recession. And patients that accumulate a lot of tartar, they're actually losing bone because the tartar is pushing the gingiva and the alveolar bone away. So just something that, if you see that on your patients, make sure that you direct them to their healthcare dentist, family dentist. And I have divided a little bit for the purpose of the presentation, the different women life stages as prepubertal 0 to 12, puberty 10-15, fertile age, which we from puberty to menopause, menopause around 45 to 55, and postmenopause more than 55 years of age. And some prepubertal oral lesions, we see developmental deformities, cysts and benign lesions like the pictures that you have on your right-hand side. Trauma, gingivitis, mucous membrane disorders like your top left photo. Dental caries, frenums like the photo on your bottom left. Gingival recession and infections. And when talking about oral diseases in infants, we see that we have definitely oral health consequences that have affected child development, their growth, health, and also the quality of our children, the quality of their life. We have also seen the sugar-rich diet and poor oral hygiene has been associated with increased caries and early onset prepubertal periodontitis. Generalized prepubertal periodontitis has also been associated with leukocyte adhesion deficiency. The localized forms of prepubertal periodontitis has been associated with PMN or monocyte chemoattractive defects as well as cementum defects. The localized form of the prepubertal periodontitis affects all deciduous teeth in the absence of LAD and may lead to juvenile cases of periodontitis. And also for my fellow physicians here, histocytosis X, hypophosphatasia, and mild forms of blood dyscrasias also have present sometimes mild or severe alveolar bone loss. And just talking about the prevalence and the distribution of gingivitis and periodontitis in children and adolescents, we see that there's a visible plaque in about 50% of 3-year-olds already, on 97% of 4 to 20-year-olds. Gingival inflammation is present in the 35% of the 3-year-olds and 65 to 97% of 4 to 20-year-olds. There's deep probing depths in 17% of 15-year-olds and 21% of 20-year-olds. Gingivitis has higher prevalence in post-molars and primary dentition, and also as age increases has higher prevalence in interproximal spaces, which then means the papilla. Highest prevalence in deeper pockets in the 15 to 20-year-olds was the mesial surface of the first molar, permanent molar. And talking about periodontal disease in children and adolescents in Latin America, that's a study of Botero and coworkers in 2015. And he identified that there was an average of 35% of Latin children that presented gingivitis, being the highest in Colombia, followed by Bolivia. And actually the lowest was in Mexico. Periodontitis was found to be in about 10% of Latin children, but it also was assessed that there was a need for further studies because in Latin America we do not have a lot of history of screenings of young children, so those numbers actually we suspect that they're a lot higher. And on looking also at periodontitis in diabetic children. You know, I know that there's a lot of diabetes in our children population, and a lot of times they're not screened adequately for oral lesions and periodontal lesions, but we know that diabetic children have more plaque and gingival inflammation levels. They also have greater number of teeth with attachment loss, bone loss. And also the periodontitis increases on children that are 12 to 18 years of age. And BMI significantly correlates with the destruction of the connective tissue attachment and the bone. When looking at the periodontal disease and Down syndrome children, we saw that prevalence and severity of periodontal disease is about 3-fold higher as compared to their siblings or to the rest of the US population. Also, Down syndrome have higher susceptibility to periodontal disease and the number of periopathogenic bacteria. It may start with deciduous teeth, and the progression is rapid, especially at younger age. Severe periodontal breakdown with horizontal bone loss is present in the lower anterior teeth mostly, but on the x-ray you can see that there's evidence of bone loss around the deciduous molars, that they're on the area of the permanent premolars. And just a brief description of Papillon-Lefebvre, because although it's a rare syndrome, it appears in 1 to 4 individuals in a million, is an autosomal recessive disorder, type 4 genodermatosis, and it goes with palmoplantar hyperkeratosis. This syndrome actually has very severe early onset prepubertal periodontitis, affecting primary and also permanent teeth. You can see in this slide that there's severe bone loss. This actually is a teenager. You can see the wisdom teeth have not developed the roots yet, but there's no teeth. So there's absolutely severe amount of bone loss with patients that have they have dentures. And they're giving me the sign of the time. I don't know how I'm gonna do that. So I'm just gonna abbreviate and tell you that juvenile periodontitis is also a very aggressive and debilitating disease that we need to take into consideration. There's a localized and a generalized form, and it has high prevalence in Latin American populations. So that's very important for us, and we have a higher prevalence in female than males, 2 to 10. And I'm going to skip here some slides. Just tell you briefly about ANOC and ANOP. There seems like there's an increase in the population. I've seen recently a lot of cases. That's a very severe form of inflammation that goes with necrosis, malodor. There's a lot of malaise. The patient feels really bad. And it actually happens usually in young populations, has been associated with malnutrition and other things. But I've seen a lot of patients, young patients, that they're not malnourished. They're actually on the upper middle class. So I think that we do have a sign of caution that there's something else going on, and maybe stress plays a higher factor than we think. Also knowing about all the hormones that periodontal disease has in relationship with estrogen and progesterone, and we know that there's an increase on pregnancy gingivitis, And also we know that hormones increase that. Also, long-term use of oral contraceptives can accelerate the progression of periodontitis. And gingivitis and periodontitis are more prevalent also on type 1 and 2 diabetics. In here, I want to go over this because this is actually an area that is important, and is pregnancy and periodontal disease. I know that there's a need for more studies, but I did a literature review of quite a lot of studies, and it seems like the consensus is that there's low birth weight was correlated with increased mean in probing depth in periodontitis, and they had higher number of sites with bleeding upon probing on the gingivitis group. There's higher levels of cyclooxygenase 2 in placenta of women that they have preterm or low birth weight associated with more severe periodontitis. There's association between periodontitis also and female infertility. And on a study with 2,423 participants that showed that periodontal disease was potential risk factor for preterm and low birth weight. And also we see that periodontal treatment also significantly reduce the preterm and low birth weight. And those are some of the systemic components. We do have studies of all of that, associating all those systemic conditions to periodontal disease. And I'll just say them very fast. I'll pretend I'm talking in Spanish. Hypertension, cardiovascular disease, stroke, hypercholesterolemia, weakened immune system, inflammation, diabetes, obesity, respiratory infections and pneumonia, ulcers, bacteria, bloodstream, transmission to family members, pregnancy and premature birth, osteoporosis, arthritis, cancer, dementia, Alzheimer's disease, and premature death. And those are your disclosures. Just a visual so you can see how diabetes can look in the mouth, and we can see a patient that does not look like there's a lot of recession in the molar area, but there's a lot of infection, there's abscesses, there's, you look at the x-rays, so although because it doesn't look like in the mouth like there's something going on, doesn't mean that there's anything going on. And I'm just going to say something very briefly about osteoporosis, because that's been also very important on females. There's a study in Spanish women that show more tooth loss and greater attachment loss. We know that there's decreased density of jawbone. They're twice as likely to present periodontitis with higher severity than women with normal bone mass density. And there's greater radiographic changes, although sometimes they don't have as many clinical parameters changes. It has been linked to disruption of homeostasis and bone remodeling, hormone balance, inflammation resolution, and women treated with estrogen also have lower prevalence of severe periodontitis. And I'm just going to say something about vitamin D. And I want to show one study here. I'm sorry? Sure, sure. And this study showed, and that was actually a study from last year, and showed that vitamin D plays a significant role in maintaining healthy periodontal and jawbone tissues, alleviating inflammation processes, stimulating post-operative healing of periodontal tissues, and the recovery of clinical parameters, and the plasma concentration needs also to be further clarified. I truly thank you for being so patient. I know that you had heard all these wonderful panelists, but sitting through this last one has been a test of endurance. Thank you so much. You want me to stand?
And I would ask Dr. Brown, Dr. McNair to come up, and now we'll take the questions from the group. If you have any, I know that there were some. Yes.
Good morning. Luis Esteves, the former chair of NHMA. And I have a question about specifically health disparities in African American women. And I know that, as was pointed out, many of these disparities are due to the social determinants of health. But I'd like to focus on a specific group of insured African American women in whom there was a significant disparity in maternal mortality. And this is a study by TRICARE. For those of you who don't know, TRICARE provides health care to the military and their families. So I'd like to know if that's been studied in either of your areas, the disparity in maternal mortality in African American women who are insured.
I can start.
Are the mics on?
Oh, okay. Can you all hear me okay? Okay, great. Thank you, sir. I'm not as familiar with the study that you described that was just released by TRICARE, but I do think that there's definitely more to be learned about what I think you're describing as a seeming paradox in a way, of there being a greater, level of insurance, but still in that community, and there being a kind of indirect relationship with maternal mortality and severe maternal morbidity. I would actually be really interested in learning more about that, and so I think that as we're continuing to do our work, trying to understand all the different nuances, that'll be a great one for us to pursue.
Yeah, I am trained as an OBGYN, but I'm a cancer doctor, and I do know, though, that this is a very interesting finding, but there's a whole, it started a whole body of research around the effects of stress and how racism and chronic stress can translate into effects on your immune system, your adrenocortical apparatus, and certainly in cancer, there's a lot of work being done that shows that you can correlate different types of stress to changes in the immune system. So I suspect that when the research is finally done, it's going to show that that is probably the cause of this. It actually has a biologic cause.
And I'll just address to this, in California, where we're doing a lot of maternal mortality initiative work, we actually are specifically focusing on African American women because of the fact that no matter what your education level, socioeconomic status level, your mortality rate is just as bad, as somebody who has a white woman who has not graduated from high school, has no insurance. And so yes, to Dr. Brown's point, definitely that's something that we're looking at, as well as the epigenetic changes that are caused by racism, chronic stress. So all of these things are being looked at, and initiatives are being implemented to try and address these issues.
Hello, my name is Diana Montoya Williams. I'm a neonatologist, and I study perinatal disparities. And my question is for you, Dr. McNair. I've studied the Healthy Start program in Florida, which is one of the largest Healthy Start grantees in the country, because the whole state uses one grant. And my question is what you think the priorities are for studying the Healthy Start program, whether we should be focused more on how the screening process works, or should the emphasis on research and providing data back to the Healthy Start program, should it be on outcomes versus the screening, or what you think is the need there?
Thank you so much. Thanks for your question. I appreciate that. And I think that what you're describing in terms of, as we think about even Healthy Start or similar public health efforts from an implementation science perspective, it's really important that we are gathering those data. Historically, that has not always been the case, but it is something that we are focused on moving forward so that we can understand, not just did we meet those goals of reducing the disparities, for instance, in infant mortality, but how did we do it? Now that does become more complicated from an attribution perspective, right? Because Healthy Start does exist within an environment where there's lots of other simultaneous activities that are happening to the women and families that are being served. But we absolutely are thinking about those data issues. As you can imagine, there are challenges as well as it relates to data in some of these programs that are not necessarily with the same infrastructure as others. So we're working through all of that and trying to think about not only implementation issues, but then how do we diffuse the innovation that's occurring across those sites? So it's a great question, and we're kind of on that road and moving in that direction. Thank you.
Hi. My name is Fatima Rodriguez, and I'm a cardiologist and health services researcher at Stanford. And Tiffany, we went to medical school together, so good to see you. So my question, I do a lot of work in cardiovascular health disparities among Hispanic Latinos, and you both mentioned something interesting about this paradox for Hispanic Latino women that tend to do better than expected, kind of given all their adverse situations and social factors. And it seems like it translates across other disciplines, not just cardiology, but also perinatal outcomes, cancer outcomes. Any thoughts or hypothesis of why this may be the case?
I think for ovarian cancer, because I'm starting to look at our data at Sloan, I think it is something molecular biologic, because we found that our ability to completely grossly resect the cancer was much higher in Hispanic Latino women than in any other group. And I think that means that the type of ovarian cancer they have, even though it may be the same cell type, something about it in terms of, for example, how it's interacting with the microenvironment, its stickiness once it has left the primary organ, there's probably a molecular biological explanation for that. And people are starting to study it. I don't know about in other, but I think in that particular cancer, that's probably the explanation.
For birth outcomes, I know that has something that we've looked at a lot in California, and depending upon who you're listening to, Dr. David Hayes Bautista out of UCLA, he'll say it's a Hispanic paradox, that it really is the support, the cultural support that Latina women have, even though you may have a young mom and the child is unexpected, it's still wanted, and so the support around the mom is something that is seen as attributable to the better outcomes. But then if you look at other researchers, other research will dismantle the studies, and they'll say, well, no, the outcomes are actually just as the same. So really, it depends upon whose data you're looking at, what you're researching. Paula Braithman out of UCSF is the one that says that no, there really isn't any improvement, or there really isn't a true Hispanic paradox. But I like to think of David Hayes Bautista as better.
I thank you very much.
I was just going to add one other point. I still have a lot to learn in this space, so it's a good question, but I also think what's interesting when I've heard of other studies in the past on kind of perinatal outcomes in amongst Black communities, thinking about background in terms of immigrant status. So has the family hailed from, let's say, West Africa, West Indies, and comparing that to those who have been born in the U.S. And I think it just gets really tricky and messy, but you see kind of these relationships in terms of length of time in the U.S. as well, right? And there's something that we know that's going on in the environment there. I think arguably we could probably make the same. I haven't seen all the literature as it relates to Hispanic and Latino community, but as you all know, the reality is that people have different lived experiences in terms of how they appear as well, and in terms of how they identify, and that maybe also create some different different outcomes
Absolutely.
as well. So I'm interested in learning more about that. So I
So
think
yeah,
it's a
I
good
do
question.
research in this area, but there's a lot of heterogeneity, obviously, within the Hispanic population that can explain some of it, so it's just kind of all lumped together. But I think there's also something to be learned when a group does better than another group. That's also a learning experience. So we tend to
Absolutely.
focus a lot on the disparities, but when there's a health advantage, we should kind of see, what is it about these patients, these individuals, that make them do better.
How do we replicate it?
Yeah.
Great, thanks.
Hi, my name is Kyle Seville. I'm a second-year dental student at Columbia University. I was wondering if you found, or if the literature has shown, that there's any stigma associated with women getting the HPV vaccine for them and their family because there's an association with it being a sexually transmitted infection. And if so, any strategies that we can use to encourage Latino women and their patients to get the HPV vaccine for them and their families.
So there's another paradox, because research has actually shown that Hispanic Latina parents, once they are educated about it, are more likely to get their kids vaccinated than other groups. And they are primarily as many people, go on the recommendation of their pediatrician. So I also think that this is an example of our country and media. There is, this has been extensively studied, and when you actually look at the reason that parents across the board in the United States don't vaccinate their kids, the number one reason is lack of knowledge. It's not the people saying, that is a tiny fringe group that is magnified by the media. It really, in practical sense, it's more people are just they don't know what it is, and they just need the education about it. Once you explain to them this is a shot that can prevent your kid from getting these 9 different types of cancer, there's almost no resistance. So I think it's really a matter of communication and letting people know what something is. Yeah.
Good morning. My name is Dr. Henny Gomez. I'm from general dentist from New York, and I'm the current president of the New York chapter of the HCA New York chapter. So my question is for you, Dr. Brown. Do you think that women that have suffered from endometriosis have a high risk to have endometriosis cancer?
The first part of what you said is a little garbled, but I think you asked if having endometriosis is a risk factor for GYN cancer. Yes. Endometriosis is a risk factor for ovarian cancer. And there's a certain type of ovarian cancer called clear cell cancer of the ovary, and that type of cancer actually is associated with Lynch syndrome. So endometriosis is a risk factor. If you have a woman who has bad endometriosis, she is at higher risk of getting ovarian cancer than someone in the general population. The general population risk is about 1 in 70. The risk of somebody with endometriosis may be as high as maybe 1 in 30, 1 in 20. Not as high as a woman who has, for example, a BRCA mutation, but it is a risk factor. And so what that really means is that as women with a history of endometriosis get older, or as you're following them with complex cysts and things that you think are endometriomas, you may want to be sure that at some point they have had some type of histologic sampling of that thing that you've been following forever that you thought was an endometrioma, or if you see that the endometriosis seems suddenly to be getting worse in terms of imaging, you might want to consider that. But yes, it is a risk factor.
Okay, thank you.
You're our last question.
Oh, no, we have to let
Good morning.
Dr. Flores has to have a question. We're going to listen.
Okay. Good morning. Thank you for the very professional presentations. I'm Edwin del Valle Sepúlveda. I am an oral and maxillofacial surgeon from San Juan, Puerto Rico. In this age of evidence-based medicine and dentistry, I'm just curious, and I'm going to address this question to Dr. Brown, but if any of the other panelists can put input in it. The expansion of the indications in ages for the HPV vaccine, what is the evidence-based justification for that? And are there any pre-screening tests that need to be completed in the older group?
So the HPV vaccine is extremely safe. Number one, there is an ongoing registry. You can look at it online. It's very safe. It's a very simple answer. The reason the age has been expanded is because the cohort of individuals who participated at 30, 40,000, whatever, girls and boys, are now at that age. And they've been monitored through the studies that were partially funded from the federal government of the United States and participated in many Central and Latin American countries. Their blood is being measured every year, and they still have the antibodies. And that is why they're expanding that age, because it's basically showing that those individuals who are in their 30s and 40s who got vaccinated when they were really young still have an active immune response. And like it or not, people still keep having sex, even above age 45. So you still need to be protected, and that's the basis for it. Pretty simple.
I'm Daniel Corin from the Bronx, New York. I am a pediatrician, and I want to go back to one of the themes of this meeting, and that is family-centered care. And my question is to Dr. McNair. I want to know what are the efforts in all those programs to include the guys? And how efficient they are, and what are the challenges that you're confronted with?
Thank you, sir. It's a really, really important question. And I think before I jump into some of the details that I can share today, I will just acknowledge, as you heard me say, when we talk about maternal health, you really can't talk about maternal health in the absence of child health, as I described, or in the absence of family health, and we know that fathers are a key and critical component of families. So we actually really do take that very seriously across the entire Bureau. In terms of some of the specifics within the programs that are in my division, within the Healthy Start initiative, a number of the sites are engaged in fatherhood initiatives and being really active about ensuring that fathers are at the table, not just kind of on paper, but are truly being brought into the process as the women in their lives and the children in their lives are engaged in these programs, ensuring and looking at indicators around fathers' participation, not just in coming to visits, but also everything from reading to your child and other types of important indicators around early childhood development. So we actually are paying very close attention to this and trying to understand kind of what the impact is of fatherhood participation. And then I'll just also add, not just kind of fathers, but grandparents, because in many circumstances, grandparents are also the primary caregivers for young children. So we're thinking about the impacts of all of those, and we absolutely do take a family-centered approach across our programs. Thank you for bringing that up.
Okay, so I guess I'm the closer. Just two things. I'm the chair of NHMA and a guest here and a pediatrician. I do want to invite you all tomorrow tomorrow's Saturday? Yeah, I'm losing orientation here. Tomorrow, Saturday at 10:30, we have a plenary that will talk about policies and practices. We've added on an extra speaker to talk about myths around immunizations, and he will be addressing HPV.
Great.
So that's an alert to you. Secondly, I do want to thank the entire panel, but I specifically want to mention that Dr. Brown and I have a personal relationship. And I want to say that of all the data she showed, especially about Puerto Rican women, of which my late sister was one, her relationship with our family and how she managed a cancer patient for 15 years is what allowed her survival. So thank you so much, and from a Hispanic woman, the relationship and trust is really what got her through. So thank you.
Thank you. Thank you, everyone. Thank you to the panel and to all of you. A couple of announcements. Tomorrow, if you were intrigued and want more on women's health, there's another session, Session B at 1:45. That's going to be covering more information on women's health. And the other thing is that lunch is going to be in here, and please go to the exhibitors, all right, because they are really helping us fund the meeting. So thank you, everyone, for your attention.